universe here, and just a pleasure to see our group expanding and all over the world. It's just really lovely, and I've been trying to gather the brightest minds and the coolest people on the planet to join us in this experience as well. So today I'd like to welcome Professor Anton Emmanuel, who was recommended to us by our bladder expert, Dr. Panikar, who said that Dr. Emmanuel is the Neuro-Gastroenterologist. And when he mentioned that word, I was like, I don't even honestly know what that is. And so maybe Anton will tell us a little bit about his journey. I just learned that he actually did some neurology training and then became a gastroenterologist. So he really truly spans both ends of the world of, these body parts, I guess, truly stem to stern or whatever you want to call it. So we will learn about this. And this is going to be an interesting take on this topic. I think, many of us in the United States have access to certain types of specialists, and we learn about this from, a single lens, possibly of just the neurologist or a separate gastroenterologist who may not know so much about Parkinson's. So I really wanted to bring Professor Emmanuel to teach us today about his views. Some of this is a little bit experimental. He does research in this. He's just really gifted in this whole area. And so really thinking outside the box, truly. So without further ado, I wanted you to teach us a little bit about your journey, why you went into this field and kind of what brought you here. I know you also work with a psychologist and you do some group classes for patients with some of these disorders. And I'd like you to either before or after your lecture, your slides, you can tell us about that depending on where you feel it fits in.
Thank you. I really am genuinely honored to participate in this, and thank you for joining, whether it's right now live or pitching in later on. I take this part of my job incredibly seriously, the part which is reaching out to patients directly. For me, it's kind of utterly fundamental to practice, and the reason I like to do what I like to do is that sense of being connected to people, and patient communication is a key part of what I believe research should be. My journey, as you heard, I don't want to talk too much about myself because that's the least interesting thing I have to say, is I originally started off as a neurologist and then went to do a research program, my MD, in the control of the autonomic nerves, the involuntary nervous system in the gut in patients with spinal cord injury. And to do that, I went to work at a place called St. Mark's in London, which is where I'm based, and became enamored of the fact that in gastroenterology, you can do things very directly to people. You can put tubes into them, you can take bits of their body out of them, it just felt much more hands-on and direct. And at that time in my life, I was young and naive, and that was an exciting part of the journey. And the reason for mentioning that is mostly partly to give the validity of what I hope I'm going to say to make sense, but also to say that that aspect of being able to do things, the practical part of neurogastroenterology is what excites me. The kind of theoretical horizon stuff is not so interesting to me in terms of sharing that. So if that's okay with you, I'll kick off and I can share my...
Absolutely.
Thank you very much, and say once again, really thanks for joining and thanks for the invitation in the first place. So don't be daunted by the number of slides, but maybe do be daunted by the fact that I speak quickly. But that gives you all the more reason to stop and ask questions of me. And I say I want to try and excite you by the prospects of things to come on the horizon, on the immediate horizon rather than the distant one. And just to illustrate the places I work in this beautiful hospital on the right-hand side, that old red brick building, which those of you who have a neurology background may recognize as Queen Square, which is the National Hospital in London for neurological disease. And this ultra-modern, ghastly, but very efficient glass and metal monstrosity, which is less cool, but more functional. And I put that in there to reflect the fact that a neurogastroenterologist has at his heart the interest of a patient in mind, but there's a reason why the brain and the gut should connect. Your gut has more bacteria within it than there are cells of your own body. It used to be regarded as 10 times more bacterial cells than there are cells of yourself. That probably isn't quite true, but it's at least twice as many. In other words, you're a minority part of your own self. There's more of them than there are of you in you. And your gut has more neurons, more nerve cells than there are in your spinal cord. So after your brain, the most nervous bit of your body is your gut. And we've all had butterflies in our tummy. We've all had loose motions before a a big lecture on an evening, say. So these things, this relationship between the brain and the little brain in your gut is kind of fairly well established for all of us. And as I said, at the heart of what I like doing is treating patients. And I'll begin with the story of a patient I've looked after. This is a 63-year-old patient who's presenting to us was from her neurologist with the complaint that her Parkinson's has been reasonably stable, but she's pretty slender. She's got a BMI of 19. That means she's underweight. She's stable on her L-DOPA, but her complaint to see me was with severe abdominal pain. Her cardinal thing that made this otherwise high-functioning woman, she's a retired geography teacher, a very active grandmother, or she'd like to have been, but her pain and constipation were what really stopped her being able to do that. And she'd become, in the year, 6 months to a year before seeing me, very much sort of housebound. Well, the first thing I want to say is that the involvement of the gut with Parkinson's disease goes way beyond the bowel. So I've shown, this is some work we did about 2 years ago in a multidisciplinary group in the UK, looking at symptoms in patients with neurological diseases, including Parkinson's. And we classify this in a kind of grid according to their patient symptoms. So here are the upper gut symptoms, nausea, reflux, etc. Here are the abdominal symptoms, pain and bloating. And here are the sort of the bowel symptoms. And along here is kind of sequence of thinking. And what it points out, and I don't want to go through detail of this is way too detailed, but to make the central point that at the very top, at the very start of all these presentations, is the idea of constipation. Constipation, and we'll talk a lot about that, and I'm sorry if that puts you off your lunch or whatever meal you're looking forward to next, but it's the bread and butter of this. These are getting worse now, but it's really the fundamental part of understanding motility. And the whole point is that pain, satiety, nausea, vomiting, reflux, the first thing we need to exclude is that the patient is constipated. And I would say in my practice for these upper gut symptoms, at least half the patients I see with that have constipation as a primary cause, not stomach problems, not reflux, not ulcers or the other things that we commonly worry about. It's constipation, which is the underlying problem in at least half the patients. Now, if we turn to the bowel symptoms, what are they and how prevalent are they? The kind of slightly staggering thing for those of you who are carers rather than patients is how prevalent gut symptoms are. And by the gut, and I use the expression throughout this, I'm talking about any bit of your digestive system from your mouth down to your bottom end. So I'll use the term gut throughout this. But gut symptoms are ridiculously common amongst us. So as many as 1 in 10 of us would be classified as being constipated by the various criteria in the dark blue bar over here. Fecal incontinence, a kind of staggering number, 2% of us, 2 to 3% of us healthy adults are fecally incontinent on a monthly basis. That's a staggering number. Means 1 in 50 people have a bowel accident, unwanted bowel accident, at least once a month. That's an astonishing number. Yet, staggering as that is, if you then look at how prevalent these things are in patients with constipation, way more. 2/3 of patients with Parkinson's are constipated. Half the patients with Parkinson's have had monthly fecal incontinence, and these other things we will allude to later on. But these are highly prevalent symptoms, and as you can imagine, they are highly intrusive. These are desperately awful, life-limiting symptoms to live with. So if we go back to our patient, what is her problem? Let's think about this. So I've said now constipation is highly prevalent. So is it simply that? The concept that we will talk about in a little bit of detail now is this idea of transit through the bowel. I like to explain physiology. I think for me, the reason, of course, is that partly it's the academic target for us, but mostly because I think one of the fundamental things for me is that if we can help the patient understand what's going on with them, we have a way of trying to help them manage their symptoms better in terms of juggling medication or lifestyles. So the problems with constipation is not a diagnosis. Constipation is a symptom, and we have to try and understand what the mechanisms through which that's occurred as. What's gone wrong with the body function for that to happen? Is it a problem of slow transit, i.e. a slow rate of movement through the gut? Is it a problem with emptying? The gut is a long tube from your mouth down to your bottom end. It's one long tube propelling things along. But your rectum is a very different beast. It isn't just a tube, it's a tank. So the rest of the gut fills up this tank, and that tank fills up and fills up and fills up. And at some point, it then says, you need to use the bathroom, and then away you go. It isn't just pushing things through as it comes down to come out. And so some people have a problem with slow transit, i.e. the traffic through is very slow. Some people have a problem with the tank. The tank doesn't work. And some people have a problem with IBS, where the nerve sensitivity causes pain, as well as the nerve movement side of things, the motor part of the nervous system in the gut causes it to move slowly. So we have to think about what the problem is at a kind of a level beyond just saying this patient, this woman is constipated. We need to think slightly more deeply. And this is the kind of response I get from most of my colleagues when I present excitedly about patients with neurogastro problems. Say, oh, what does it matter what the cause is? Just give her some Miralax is the equivalent. Just give her that and she'll be quiet. What does it matter? Just send her to a surgeon. They'll remove the bowel. That's much easier. And for my neurology colleagues, I get the thing, well, what has this got to do with Parkinson's? This has got nothing to do with Parkinson's. Parkinson's is a disorder of the movement, of the motor system of the body, not the motor system of the internal organs, which are a different kind of muscle. So what I want to try and excite you about is that there is a relationship, and it's one which is worth getting to know about. So I'm going to apologize for presenting some of our in-house data, but I think this really helps that kind of grasping the physiology. This shows a healthy individual, one of my research fellows as it happens, over a 24-hour period from 2 o'clock one day, as you can see, to 2 o'clock the next day along the horizontal. And going into the screen is the fact that this patient, this healthy individual, has a tube in his bowel passed via the bottom end, which has multiple recordings of pressure throughout the gut. And the height of this little on the vertical axis here is the pressure that's generated in the bowel. And what you see is that through the day, this healthy young volunteer has contractions which begin over in that right-hand side of the bowel called the cecum. That's right at the very top of your bowel. And it sweeps down, and some of them come all the way down to the bottom end, to the rectum. Some of them stop halfway. When you go to sleep, your bowel goes to sleep. After a meal, you get these clusters of these contractions bringing things down. And every so often, some of them come all the way down and you have a bowel action. And all of these contractions are antegrade. Now, they're moving forwards from the top to the bottom. Very few are retrograde. There's a few of these scattered there after breakfast. Okay, that's a healthy individual. And some of these, as I say, come all the way down and you have a bowel action. Here's the patient with Parkinson's disease. Not the same woman I showed you now, but another woman of similar age, a bit younger. And these traces could not look more different. They really could not. There's no peristalsis, there's no green hills, there's no relationship to meals at all. There's lots more backward activity where things are staying in there for longer. So you can see that that conduit, that pipe work, pushing things down to the rectum is just not doing what it's meant to do. This is profound, severe slow transit in a patient with Parkinson's disease. Okay, now it's important to understand that because that is there, and as a mechanism, when we think about Parkinson's being a movement problem, it's also affecting the internal muscles. It may not be the same kind of muscle as your arms and your legs have, but it's affected by a nervous process, because most of what we alluded to earlier on is kind of butterflies in your tummy feeling, or that kind of rushing to the bathroom when you're a bit nervous. All of those things are mediated. They're managed by this autonomic nervous system running through to the gut, from your mouth down to your bottom end, to be like the kind of accelerator or brake pedal in your car to move things forward or slow things down. And there's a beautiful yin and yang in harmony in health where that happens without you thinking about it. Yet when that system of nervous control gets messed up by diseases like Parkinson's, that whole traffic gets messed up. And it's a bit like when they stick a traffic light in downtown on a bad day, things generally start getting backed up behind it. They've put a temporary light in there, but that temporary cessation, that temporary change to the nerve architecture of the roads results in this huge problem with transit getting through. And then you get sudden rushes of things, long periods of inactivity, sudden rushes, and that whole regulation has got messed up. And I don't want to go into the detail of how that happens unless it comes up with questions, but that's the mechanism. And that movement of content comes down, but it also relates to how the bottom functions. And I won't dwell on this slide other than to say that in a healthy individual, if we look at this time zero when a person opens their bowel, this is a kind of back to front graph. What you see here is a healthy individual, and in that half an hour before a bowel action, there's lots of these so-called propagator sequence. Lots of contractions bringing things down to the rectum for the rectum to then squeeze out. Whereas here are the patients with Parkinson's, and what you see that there's much less activity. In that half hour, 1 hour, 2 hours beforehand, there are no more contractions. Everything is quiet. So not only is traffic slow, but the timing of traffic to time when the lights go green is also gone wrong. So there's less coming to the traffic lights, but even when the lights come, the cars are held way upstream so that emptying time comes and there's nothing there to empty. And this is manifest here. So here's a way of looking at that pictorially with an isotope scan. Here's a healthy individual before a bowel action, after a bowel action, lots of clearance of stuff in that left-hand side of their bowel, lots of the stuff in the rectum, the brighter it is, the more it is, has cleared out. There's still some left there. Here's a patient as it happens with MS, but the same thing happens in Parkinson's. There's before, there's after. There's really no difference in those images. And we can show that in a variety of different ways. I don't want to dwell on that. The scan I showed you before was kind of expensive and fancy. This is a much cheaper version of doing the same thing, where a patient swallows little capsules which have different shapes inside them, and we can then study their traffic through the bowel and see where they are at various times. And you can see everything's got clustered down in this patient's rectum. Now, I mentioned there's this thing about getting stuff down there, but then getting stuff out. And the other part of the thing that goes wrong with getting stuff out is that normally that pelvic floor, so you've got this beautiful, clever, highly evolved pelvic floor, which is basically a muscle which slings from the front of your pubic bone, the front of your tummy, to your back, to your sacrum. So imagine kind of like a plate of meat running from the front, anchoring like a hammock to the pubic bone and anchoring at the back to your sacrum. And that hammock is tight and strong and supports all your pelvic organs, or should do. Yet once a day or twice a day or whatever it is, when you want to open your bowels, and more often when you want to pass urine, that pelvic floor, that hammock relaxes all the way down, allows the angle of the rectum here to the anus to straighten out. And so that normal angle that maintains continence so you don't have an accident suddenly opens up to be like a nice funnel. At the same time as you get the urge to open your bowels, everything relaxes, and that pelvic floor, called the puborectalis muscle, relaxes at just the moment when your abdominal muscles contract and your anal sphincters open, and you have a bowel action, and you get off the pot and you're feeling delighted with yourself. That's what happens in health. But in patients with Parkinson's, unfortunately, some of you who have Parkinson's will have these so-called dystonic phenomena affecting your wrist or your neck or other parts of your body. Well, guess what? Unfortunately, some patients can also get a dystonia of that pelvic floor muscle, puborectalis. And there's some good old data showing that, if you have a willing surgeon or gastroenterologist who's knowledgeable how to do it, you can, under ultrasound or X-ray guidance, put Botox into that muscle to relax it, and you'll get a response which is pretty quick to come on. Doesn't necessarily last much more than 4 to 6 months in our experience, but it can be repeated if need be. Now, if we return to our patient, she's by now, we changed her regime of laxatives, and we tried to improve her function. And we gave her some Botox into her pelvic floor because she had this dyssynergia, this problem with that pelvic floor muscle. And we did injections about twice a year. And for about several years, she went along beautifully. She then started a new medication for her hypertension, which then made her more constipated with much more of a transit problem. And instead of having that X-ray I showed you with all the markers clustered in her pelvis like before, she suddenly had all the markers, this is a different scan obviously done a few years later, clustered around her bowel. So now she's gone from having that evacuation problem that I showed you the slide of earlier on to having this more generalized slow transit throughout her gut. And there are drugs out there to manage this. So these are some of these drugs I know are there's a difference in various countries about what's available. Prucalopride also has the name Resolor or Resotrans, depending where in the world you are. It's gone through approvals in most parts of the world. And there's data showing that it can accelerate transit. It accelerates transit through the gut to improve the rate at which things propel down to your rectum and then can be emptied from there. And there's beautiful data in particular in patients who have this symptom of infrequent stools and hard stools. Not so much difficulty in emptying, but for that symptoms of slow transit, it works a charm. Now, as I said, the mechanisms of what happens in Parkinson's disease are, for most patients, that the mechanism is of a system where the bowel muscles slow down because the nervous system doesn't work as effectively in the gut. And that mechanism, like the traffic lights being put into downtown, means that every so often there's a sudden rush. And so when that system suddenly rushes through, if you don't have good control of your anal sphincters, which is especially something which may affect women who've had children or who've had traumatic injuries down to that part of their body, those sphincters may have been dormant for many years. But when you suddenly have a huge inrush of material once in a blue moon of stuff coming down there because there's too much laxative on board and the coordination isn't quite right, you can then run the risk of this devastating symptom of fecal incontinence, which is so life-limiting. And the fear of incontinence is so paralyzing. If you think of how any of you who are not patients, how dreadfully you'd suffer if you'd once had an accident on your way to your kid's school, on the way to work, in the bus. If you'd ever had an accident, you'd never make that journey again. It's so limiting. And you know, a half of patients in every survey that's been done of this question with Parkinson's experience fecal incontinence. It's a devastating symptom. And it's not just women, I should say. It's men who've had hemorrhoid operations, people who've had their prostate dealt with or had radiation down to the pelvic floor. All the things that happen to us as we get older, those make our sphincters more vulnerable. So we must, you know, present with these things because there are things doctors and nurses can do about this stuff. There are devices we can use to improve continence. There are medications we can use to desiccate stools so they're not so liquid and not so likely to leak. I want to excite you other things that can be done, and then hope you can come back to me with questions. There is a lot. I mean, half of my working life is spent with patients with neurological disease, and to tell you everything I do would be tantalizingly irritating. So I just want to excite you that it's worth presenting and worth asking, but please do feel free to ask things in the question time, or I'm very happy for you to share my emails. I'm a strong believer in being available. My father was an illiterate man, but he said to me when I qualified, the only two things you need to be as a doctor, son, are number one, to be competent. He said low bar, and number two, to be available. And I strongly believe in my father, but I strongly believe in those things. Now, I don't want to talk too much about academia, but some of you may have read about this stuff, and it's sort of what is exciting one part of my research team in this area. And you'd have possibly heard about this Dutch neurologist who came up with the idea that Parkinson's may actually begin in the gut. It may begin as a disorder which begins low down, and then there are nerves which connect, and a particular nerve called the vagus nerve, which goes from there to your brainstem. And it may be that there is some slightly greater porosity, that your gut becomes more porous. The kind of very tight brickwork you normally have in your bowel becomes slightly more holy, allowing things to enter and then travel up the nervous system to the brain and then cause this degeneration. And he's shown some nice sequential work suggesting that that may be the issue here. And we have done some work showing that, essentially, just focus on the right-hand side of this figure, that in animal studies we can induce a little antigen, a little foreign protein, to enter through the gut when it's made more holy, when the brickwork has become looser. That can be picked up by the vagus nerve in the animal's model, and then they can travel up the nervous system to the brain and cause degeneration, possibly in the brainstem. And this paper about 3 years ago really sort of changed the way people saw a lot of this area. It's gone from that point of being an interesting speculative idea by this European guy to being something now which was much more alive. When this is an animal study, as you can see in mice, showing that if you took the gut flora, the bacteria from a patient with Parkinson's disease, and put that into a mouse model with a leaky type gut, you could make that mouse have Parkinsonian type dysfunction by giving it the stools, the bacteria from a Parkinson's patient. That's kind of revolutionary stuff, and it opened up all sorts of interesting ideas about how we could go with that, which you may be interested in talking about. At the crudest level, what can we do with that? We can give you probiotics. The problem with probiotics, and this question comes up a lot, and I hope I'm not going to dash any long-cherished hopes, but your bacterial flora, your gut, is as individual as your face. It's as individual as it's more than your face, it's as individual as your fingerprint. And the problem with that is that the idea that there's a single bacterial product that's going to be the solution for everyone, let alone everyone with a disease, which becomes even more complicated. It's just not there. But the point about these studies is not to say forget probiotics. It's to say that you may have to try a variety and you may still not be very lucky. But when studies have been done, here's with a fermented milk product with a prebiotic. In other words, rather than the bacteria, as well as having the bacteria, which is the probiotic, you also have a prebiotic, which is basically the kind of compost that makes that bacteria live in your body. It's obviously not real compost; it's a food compost, which you can eat. And you can show that if you compare experimental patients given that product versus placebo, you get these very significant improvements in gut function. Again, I don't want to try and necessarily, I'm here absolutely not selling any product, but I want to suggest that there is some mileage in trying probiotics, but to be prepared for disappointment. It takes 4 weeks to notice an effect, and it's still only about half patients who'll get a response, and that's in a clinical trial. So probably in real life, it's probably a few less than that. The crudest way of changing bacteria in the bowel, as you saw from that animal study, was to take feces from one healthy person and put it into an unhealthy person. And that's been done for a few GI illnesses with good effect. The problem with that is that when you transfer feces, we are transferring some good bacteria. We may also be transferring things we don't want to transfer. So what this study told us is that in certain types of animal, when you transfer stools into them, you can also transfer things we don't want, like changes in how their brain experiences emotions and experiences elation. And so the transmission of mood disorders, eating disorder behavior has been seen in some patients with fecal transplant. So we are generally very cautious, and I put a hold, if I'm honest with you, on our clinical trial that we are undertaking on fecal transplant for Parkinson's and MS patients. But this slide, enormously complicated, is to excite you that bacteria are going to be one of the things on the horizon, maybe the 5 to 10 year horizon, but this is an MS, but similar work has been done in Parkinson's. Beautiful paper from our highest ranking kind of journal, and it shows the effect of the disease itself in enhancing certain bacteria, the effect of the disease itself when added to some immune therapies, and the effect of therapy on its own. So we can basically begin to pick out in this kind of complicated fingerprint what part is disease, what part is treatment, what part is you, and what part is the bit that we're aiming for. What family of bacteria or families are we aiming to enhance? So bacteria are there, and they will be the story for tomorrow. They may even explain how this thing goes up the vagus nerve in the first place. But enough about that. The last 5 minutes, if that's okay, and we're not getting too many rolled eyes from all the colleagues in the Alliance, is just to talk about the practical things that are out there. We had this idea of a pyramid of therapies where at the bottom, where the most patients are treated successfully, are these simpler conservative options, such as altering diet, lifestyle, and then simple laxatives and suppositories. Then there's the options for something which I'll talk a little bit about for a minute or so, something called transanal irrigation, which is very much on your immediate in the immediate future for you guys in the States, and is here for many of us in Europe. And then the much more complicated, rarely done things. Remember, please, that bowel incontinence is the thing that is the most debilitating. You've seen how agitated I get about incontinence, because it's a symptom that most of our patients don't like talking about because it's so taboo. But please feel free to ask and to mention it, because it galvanizes doctors, even those of us who are less interested in bowel symptoms because they're a bit boring. Once we know our patients are suffering incontinence, it's a real call to arms. So please, if that awful symptom happens to you, then report it, because if you don't, we know that all sorts of terrible things go alongside that. The anxiety, the low mood, disturbance of sleep, not feeling very glamorous, not feeling like you want to socialize. All these things are secondary and often related to continence. And we did a very large survey of patients across the world, and I've always liked this quote from a patient, which is that, I'd have an accident about once every 3 months, but even I only had an accident once every 3 months, I was terrified all the time of when it's going to happen, because I didn't follow a nice clockwork thing. It was just random, and I would think each time I was fine, this is all very well, but it's a calm before the storm. So what do? We strongly believe in diaries. Please keep a diary before you see your doctor, because a snapshot of what's happened to you today or yesterday is not the same as keeping a diary. So you don't have to keep a sort of, this is the diary we send all our patients, but you'll just make a little note in your phone of when you've had a bowel action, how long it took, how much of a strain did you have to use a laxative. Just keep a few notes. That really helps supplement the background for us. There are things in that green layer of the pyramid which are very evidence-based, and I hope that will come up in a discussion. There are simple suppositories and enemas. There are use of Dulcolax, which is a stimulant, suppository like Senna. There's stimulation with a finger. It's not the nicest thing in the world to do, but if that means you remain your independence and you don't need somebody else to help you, for some of our patients, that's exactly what they want. Using the gastrocolic reflex, so that having a bowel action or attempting to after a breakfast, after a meal, is the natural thing, because you have these natural waves, those green hills I showed you earlier on, those occur after meals, especially after breakfast. So time it for then if you can. Abdominal massage, we can train patients how to use a massage technique with their right hand, or get their carer or loved one to do it, moving across from the right to the top of the bowel to the left. It's been shown to, there's 2 studies showing benefit in neurological disease. Stimulation we've already mentioned, oral medication, and there are a few things about exercise, and I would like to say, exercise sounds great, and it is important for your general health, and obviously follow your physiotherapist, follow your neurologist guidance, but don't expect it to have a dramatic effect on your bowel. This study told us that you need to be walking 4 hours a day to improve constipation. Well, none of us on this call are walking 4 hours a day, I should imagine. So don't expect walking to cure your constipation. God forbid. Do it for other reasons. Fluid intake, equally, you can't superhydrate your bowel. If you drink less in a hot climate, you're going to dehydrate, and that your bowel will take the price. But once you take about 1,500 mils a day for an average sized person, once you're drinking more than 1.5 liters, you have no way of holding on to that in your bowel. So drinking liters and liters and liters and liters of water, hoping it's going to selectively stay in your bowel, it just ain't. Okay, you'll just end up peeing out and then having all the problems of rushing to the bathroom and waking up at night. It's no use to you. Beyond 1.5 liters, you can't hold extra water in your bowel. That's what all these studies say. So don't torture yourself to try and drink more. You can't cure yourself. Drinking less than 1.5 liters will contribute to constipation, but drinking much more than that doesn't help. So don't do it. And the final point I want to say is about fiber. This is a complicated slide, and I won't dwell on it, but it makes the point that fiber supplementation helps only if you're able to do it alongside taking a little bit of exercise. And that doesn't mean walking 4 hours a day. It means doing something active. So you can take more fiber in your diet, but once you're taking more fiber in your diet, it won't have a prokinetic, a propulsive effect through the bowel. It won't give you those green hills I showed earlier on without doing something like a 5-10 minute walk, especially after meals. So the classical thing we recommend, a bit of fiber in your diet. Don't overdo it because it makes you too windy and bloated if you do. And then take a little walk, and then try and visit a bathroom after a hot drink. That's the best way of trying to get your bowel to work naturally. Now, I will, for a second, I don't want to dwell on questions which will come up probably in question times, but I do want to talk about is the fact that there's this system of catheters that they are very much. I'm coming to the States. I was meant to be coming there in March to the FDA to present about this technology, and I think that it's been rescheduled for February next year. But there are systems being developed where patients have access to a catheter at this end, connected by a water pipe to a reservoir, and then either a hand pump like here or an electronic pump, and this is passed into the bowel, and then a balloon is blown up to hold it in place, and then that can be either controlled by the hand pump or by this thing, and then water is then drained from there into the bowel. When it's in the bowel, it stretches the rectum. When it stretches the rectum, it causes a reflex contraction, and you clear your entire bowel. Here's those images I showed you before of a patient before. This is a patient with spinal injury, so a very profound bowel injury to their gut, and lots of stool in their bowel. After an irrigation, they clear their entire left colon out. This is a very effective way, so it's done every 2nd or 3rd day to completely void the bowel, thereby meaning there's less chance of incontinence. So the final thing I want to say is that can be tailored to the patient's best care. We know, that we can adjust laxatives, we can adjust how you irrigate, you can adjust the time of day you take your meals. There are a whole variety of things we can do to try and tailor therapy. So for me, I want you to please start presenting, start mentioning these symptoms, because there's often simple things that you or we can do to try and improve quality of life. The question that always comes up at the end of this talking about this is that, isn't it dangerous? Well, if we look at the risk we have is of perforation, of tearing of the bowel. That risk is 2 per million. Now, that's a very small number. If you bear in mind that when you go for your colonoscopy, those of you who have reached a certain age and have been asked to have a colonoscopy, the doctor there will quote you a 1 in 1,000 chance of tearing your bowel. So 1 in 500,000 is it's a risk to put into perspective. Yes, it is a risk, but it's a relatively low risk. And if you're doing it 3 times a week, it's something which we counsel people about, to do it safely and effectively, but it's not something to not do it about. So listen, I've talked a lot, I've shared a lot of stuff that is done by our group and others. I hope I've encouraged you to speak about your bowels much more, and you can begin that by now asking me anything you like. Nothing's off the table. Sorry if I went on a bit. This is where I find out that no one's there now.
Unmute my, okay, that was amazing. Wow. Just really great. Maybe, so either, Anton, we can do one of two things. We could either go back to maybe the slide with the medications with the different types of, you know, the osmotic and things like that, if you would like just to talk. I wanted to clarify a few things with the types of medications, because I think there's a lot of confusion about this.
Okay. Yeah.
So maybe we could just go through kind of the list of things that I understand are ways to treat, you know, bowels. And one is, what is a bulk forming agent? What does that do?
Okay. So a bulk forming agent is the same as fiber. It's an agent which basically goes into your gut and sits in your gut and causes the bacteria to ferment content, thereby making new chemicals which act as a stimulant to your bowel. And the other thing that fiber does, or bulk, is to bulk the stools up, literally to physically bulk the stools up, to bind onto bile and to bind onto water. So you have 2 effects. One is to ferment the colonic bacteria with the bacteria, creating new chemicals which act to stimulate your bowel. And the other is to create bulky stools. And together, that effect means that things come down to your bottom end. The problem with that is that for most patients with slow transit, which is the majority of patients with Parkinson's, they already have maxed out their fermentation effect. They've already at a ceiling. And when you give them more of this physical bulking, they can get more bloated and windy. So if you're on a very, very low fiber diet, because that's the way you like it, then fiber supplementation, bulking agents can help. But if you're already taking lots of cereal and vegetable fiber, there's no benefit in that.
And so things that are examples of bulk forming agents are psyllium, which is a husk, right? A seed husk, Metamucil.
Yeah.
Metamucil. Polycarbophil, which is fibercon, and then methylcellulose, which is citrus cell. Those are the things that are available here. And so you said that sometimes they can actually, because of the fermentation issue that's already present in Parkinson's patients' guts, it may actually make you more bloated or gassy if you take this.
Exactly. So the patients for whom that's most beneficial, those bulking agents are helpful, are the patients who have so it's not for patients who have hard stools or infrequent stools, really. It won't do much for you. It's for the patients who go to the bathroom and then when they sit there, you can't get it out. You get the urge to go, but you can't get anything out because the stuff hasn't come down. So fiber helps by getting stuff down there to then distend things out to make them come out. So it's for most patients who have incomplete emptying, a sense of not being able to void, having to use a finger. At that point, those are the drugs to use, not if you have infrequent urge or very hard stool.
Okay. And then what is a lubricant like glycerin? What is that used for?
So fantastically effective, again, for the same group of patients. So if that bulking agent doesn't help you and you've got stuff down in your rectum and you can't get it out and you don't want to be doing the undignified thing of a gloved finger, a glycerin suppository is a fantastically effective way of getting stuff out of the rectum. Probably the single biggest use intervention in my PD patients with puberectalis problems, that second kind of issue. Because what it does is the glycerin has 2 effects. One is to cover the stool. Often you have this very hard, dry stool, which has been there a long time, not coming out. It coats that so it comes out a bit easier without causing so much pain and bleeding. But secondly, the glycerin has an irritant effect on the rectum and makes that squeeze. So glycerin for patients, again, the same patients, if they don't respond to bulking agents, then go down the glycerin route.
Okay. And then there's a thing called a stool softener. So that's like the Ducosate that we have here. Could you explain what that is?
It's of almost no help on its own. So docosate is really does what it says in the tin, as they say here. It works to soften the stool. So if your stools are rock hard and coming down there, but when they come out they're rock hard, then they will soften it. But that is very rarely of any use on its own. For most patients, docosate needs to be used as an adjuvant, as an add-on agent. So you need something else to do whatever it's going to do, whether it's a glycerin or whatever else. And the softener, docosate, is almost only ever any use as an adjuvant.
Okay, that's good to know. And then there's two other things, osmotic laxatives, I guess, that are like Miralax or Mavacol is what you listed. And then that's also milk of magnesia is a different one of the osmotic ones. Could you explain how that works?
Yeah, sure, thanks. So we tend to say, please avoid those agents in people who have any risk of incontinence. Those drugs work by binding water into the stool, and therefore they make, the more of it you take, the more water you hold on to, therefore the more of a flushing effect you get, which sounds great, except that they are unpredictable for many people. And the longer you use it, the more unpredictable it becomes. So that you run the risk of saying, yeah, it works 7 days out of 10, but another 3 days I have to rush to the bathroom. And so if there's any problem with continence, either obstetric related or previous surgical therapies to the bowel, then we generally keep away from Miralax and drugs like that, because they run the risk of incontinence, which is so disabling.
Okay. And then the last thing I have on the list is a stimulant, like Senecot or Dulcolax. Could you explain what that does?
So these are really very important agents. So again, if I said there's one key agent for me for the lower gut, it's the glycerin. For the top end, for these patients with slow transit, where those things aren't going to work, the glycerin, the fiber is going to work because they're not going to do what we want. So if you're a patient who has a symptom of infrequent urge or hard pellet stools or both, then you almost certainly have slow transit. And in that situation, then these stimulants are really helpful. That's things like Senna, which most countries can buy over the counter. And Bisacodal is the other generic name, and it's Dulcolax. And those agents basically work on the bowel muscles to make them squeeze. So even though the nerve supply to the bowel is impaired, it doesn't matter because it makes the bowel muscles contract to propel things through. And therefore they work fairly well for patients with PD and who have slow transit.
Okay. That's really helpful just to go over all of this.
Sorry, they're best taken overnight. The way they work is they glide down into the colon, and then they get broken down and metabolized by the gut bacteria. And so if you take, the best way of taking them is to take them overnight rather than first thing in the morning. Take them overnight, they work their way through the gut while you're sleeping, and then they start doing their thing in the morning. And I keep saying the single biggest thing that we ever do to make people's bowels better is to introduce a regime, to get them into a bowel pattern where they take bowel management seriously by taking it at a fixed time, preferably in the morning after breakfast.
Okay, that sounds really good. That's helpful. There's a question about Botox and who might be a good Botox candidate, as you mentioned, and then also, are most doctors familiar? Is it a gastroenterologist that would do the Botox?
So I'll answer the question I can answer to the first part. So the symptoms are those where patients will say, I get the urge to go to the loo doc. If stuff comes down there, I get the urge, but when I go there, I strain, it's like closing, it's like a door's closed and I'm trying to squeeze. And that's exactly what's happening. The pelvic floor, that hammock, instead of relaxing and giving, is pulling up high and tight. And the more you strain, the more you make that muscle tighter. Whereas in health, when you strain, you drop that muscle. And so the symptom the patient gets is that urge to go, followed then by inability to void, and then a need to strain more and more. Eventually you relax. That makes the pelvic floor drop down a bit, which then makes you go a tiny bit. So that feeling of almost paradoxical emptying. You can't go when you want to. you stop and then you pass something small out. That's classical of it. You don't have to do that X-ray test I showed in the picture. You can just, a doctor can diagnose that with a finger when you're asking you to strain, and then inject there. Now, in the UK, that process is done by almost every colorectal surgeon. It's the first thing they're trained on, pretty much, if you're a bowel surgeon, because it's kind of pretty safe and generic. It's done under X-ray or ultrasound guidance. I know from colleagues in Australia that it's often the gastroenterologists who do it there. I have to be honest and say I don't know what the state of play in the US is, but it's something which mostly is in the GI domain with a surgical or physician.
Okay, that sounds good. There's been a question about how, like, some of these medications, they say, I guess because they're over the counter, that you shouldn't take them on a chronic basis.
Yes.
Could you speak to that? We kind of went through the list. I can rename them. I think specifically people are asking about the Miralax or Mavacol. But if there's other ones that, maybe you could just speak to how often you can take them and if they get addictive or whatever.
Yeah, no, thanks for that. So there's a few parts of that question. It's an important question and one I should have answered. So thank you for holding my feet to the fire. The thing to remember is that almost all these over-the-counter laxatives, there has to be a kind of a user's directive given by the manufacturers to avoid them being sued, which is to say, don't take it for longer than 2 weeks, because what we don't want is a patient who's never been assessed taking this drug indefinitely and then masking their ability to have they may have a tumor or an obstruction or diverticular disease, and that's what we don't want, and by masking it. So that's the reason it's there. Is there any safety issue from long-term laxative use? There's lots and lots and lots and lots of data showing that there's no increased risk of making the bowels slower. There's no increased risk of bowel cancers. There's no increased risk of have people go off their food. All the things that have been there as old wives' tales if you use laxatives long-term, that doesn't happen. But what does happen with long-term laxative use is that your body can develop tolerance to certain agents. And you find that I've been using whatever it is, say Bisocodyl or Senna for a long time, many years, absolutely fine. Suddenly one day, 1 week, it stops working. Then you may need to change temporarily. So what we often prescribe as a drug holiday, we'll say, and you're familiar with this in the whole PD world, of course, we'll say stop using that particular stimulant for a while, switch a different stimulant, or use a softener plus a bulking agent or something, and then go back to the other. And that works very well. Most of our patients, as I said, are managed in that bottom part of the pyramid successfully by juggling laxatives.
Okay. Do you have resources that you could kind of maybe connect us with if there's handouts that you give your patients?
Yes.
I think that would be amazing.
Yes, I didn't want to sort of flash there because they are very self-explanatory, but they are kind of probably, if that's okay with you, gives me a chance to mention a little bit about our group. This is not meant to. You're very welcome to come and join us in London if you want to travel from the States. But what we have is a group which began as kind of a research program and has now become it's self-perpetuating, where our carers and patients with PD, and increasingly now some patients with spinal cord injury join, where they are essentially they're facilitated by one of our group or a distinguished visitor who's across. So they'll present something around physiotherapy for the pelvic floor, urinary incontinence, bowel evacuation techniques, biofeedback, something along there. And every 2 months, we have a 2 to 4 hour meeting. The first half an hour, 40 minutes is kind of mingling. Then we have a half an hour presentation and however long questions go on for. And then there's a kind of a free for all for an hour and a half where we'll talk about a lot of help for our research programs. We get a lot of feedback from patients saying, don't use that questionnaire, that is useless, or do ask this question. As well as sharing stuff. People say, look, I found that this supplier stopped doing this, but I found this supplier. And so patients cross-fertilize stuff that they do in different regions. And that's been just so brilliant. They have their own little social group that they form now. So that for me has been the single biggest thing that's
I love that. That's amazing.
We've generated resources. It's been all filtered through the patients who've essentially, they created a little booklet of all our information under various settings, and that's not, it's in public domain. There's no intellectual property. I'd like that to be shared as widely as possible.
Okay,
That's
yeah,
something
we'll
for
just
long term.
link it under your talk, and then yeah, I think that would be amazing, and it will probably answer a lot of these specific questions too. There's been a question about how much Miralax. So it usually says 1 capful. Can you double it? Is that okay?
So Miralax, I looked up thanks to you, Indu, to see what the translation was in terms of our product, and you can use, and I said this very carefully just to make the point about safety rather than say this is what you should use. You can use the equivalent of up to 8 capfuls a day. Now,
Wow.
you don't need to, but up to that amount is safe, providing you have good kidneys. Because the one small issue, if your kidneys are slightly on the zip, is that if you absorb some of that stuff, you may not clear it out of your kidneys so well.
Okay.
But the point is not to say you need that much, but you can use more.
Okay.
And as the mechanism suggests, the more you take, the more water it holds on to. But be careful.
Yeah, I think anytime you're going above, 1 or whatever capful, probably just talk to your doctor. But we have sometimes patients that have taken 2 under the guidance of a gastroenterologist, 2 capfuls. There's been a couple questions on colonoscopy prep. Some people are even wondering if they need colonoscopies as Parkinson's patients. I mean, I usually get my patients to get colonoscopies because I don't personally think that their screening otherwise is adequate. And my husband's a radiologist who would have you think otherwise. But, I think that, our patients live near normal lifespans. I want us preventing all the things that are bad that can happen to them. So, but maybe you could speak to that and also the prep, because I know sometimes our patients don't clean out very well and then they have to go back again and try to.
Yeah. So that's a really good question. And I think you're probably ahead of the curve of us in the UK, where we're a bit more laissez-faire about this, unfortunately. The fact is that most cancer, every bowel cancer is curable if it's picked up at the right moment. If we can pick up a bowel cancer at a stage where it's confined to the lining layer of the bowel, it's completely curable. Now, the reality is that curability reduces as the further it's spread, and that reduces according to how long you've had the disease. Now, the problem for our patients with PD or any other neurological disease is that they don't present with symptoms as early because their underlying disease complicates bowel function, as we've said many times, constipation, incontinence. And it's tempted to say, well, that's all PD related. So for that reason, I, like you, try to encourage patients to think about having a colonoscopy, especially if they have any of the alarm features. That doesn't just mean symptoms, but it means men. Being a man is an alarm feature, unfortunately, for bowel cancer. Being over the age of 70, having any first-degree relative who has a prostate, bowel, or or breast cancer. Those 3 cancers are strongly associated. So any first-degree relatives, especially under age 50, that puts you at high risk. So in those patients, I sort of insist. For the rest, I try and encourage them early on. Now, what preparation to use? This is a situation where, in a healthy individual, and I shouldn't really say this, but here we go, the diet doesn't make that much difference. You can providing you reduce the amount of residue for 24 or 12 hours, you're okay. In a patient with slow transit, i.e. most patients with Parkinson's, you have to, please, for your sake, be really observant of the low residue diet, if possible even longer. So most preparations say 24 hours. If you can make it 48 hours on consomme, jelly, thin soup, that kind of stuff, that would make such a difference, because that's the thing. What holds up the stuff is not that you don't get the prep down, but that fibrous stuff doesn't get pushed through, and that limits the view a lot when we're trying to find. So if you can try and, for 48 hours, if possible, go to a low residue diet, that makes a massive difference. And as far as the preparation goes, they're usually liquid prep. Try and, they'll often say take it over an hour. That's really hard to do for most of our PD patients. So we tend to say put it in the fridge, let it go cold, which makes it more tolerable. You don't have to do just tap temperature, and then sip it. If you get it down over 6 hours, that's fine. The problem with taking it slower is that it may work a bit slower in terms of meaning that you may have to stay up till midnight to clear your bowel, but at least it's going to work. The worst case scenario is that it doesn't work and you have to be brought back for double prep or something else, and it's just so undignified. So no, take it slowly, keep it cold, be really observant of the diet.
Okay, that's really helpful. There's been a couple questions just about bloating and gas, if you have any ideas. I think some of these patients are on Miralax. Somebody else was talking about bloating and gas for 6 months. I've been treating my constipation with stool softeners, Miralax, and Senna. now taking Miralax, have a bowel movement every day with no problem, but the gas and bloating does not go away. Beano, Gas-X, antacids, all with no relief. Any thoughts on that?
Yeah, good and common question. So the first thing to say is that the question is absolutely right. The bloating is not due to extra stool in your bowel. If you think about the volume of stool you're passing, it's tiny amount. It's the volume of a pair of socks balled up. If you think about the volume of distension of your abdomen, it's massive. It's several liters of distension. That can't possibly be stools. So this is not really, so sometimes patients flog their bowel really hard to get more out and they still stay bloated. Most of the bloating in Parkinson's disease is due to the abdominal muscles of the wall becoming slack. So it's not due to extra gas either. If you do x-rays or CT scans, there's no extra gas in their guts. The problem is the abdominal musculature becomes slack. And that then means that all these organs pressed away in your belly, your liver the size of your head, 8 meters of intestine, kidneys, gynecological bits, all of that is pushing against this normally a very firm abdominal wall, but now that's given, it's gone outwards. And therefore the bloating is mostly abdominal muscle tension in our experience. And so one of the things that's come up from our patient group has been the idea of trying to exercise by doing, and it's amazing, we're trying to get it published at the moment, swimming on the belly. Those people who are able to not even swim, but just lie in water so that they have gravity defying with water causing upward pressure on the abdominal muscles, seems to reduce abdominal girth over a course of a few weeks by basically increasing wall tension. And I first heard that this is just nonsense. And then these guys have led the study themselves and blow me down. We do the measurements. We don't know who's in the group. They don't smell of chlorine when they come in. There's a definite change in diameter, which when we unblinded it was in the swimming group. So yeah, that seems to be for us. That's what lots of talk about whether certain probiotics will help. Back to the same thing I said about probiotics. Yes, you may strike lucky and get a probiotic which makes you less gassy, but it's a lottery.
Okay. And then what about that abdominal massage thing? Maybe you could talk for a minute or two. We're almost at the top of the hour, but it sounds very interesting.
Yeah, so sorry for talking too much, but yes, I mean, abdominal massage, again, is something which our site is skeptical about, but again, seems to work. So basically what you use 2 or 3 fingers, and you start off on your the right-hand side of your bowel. So if you imagine the point where your hip bone is, imagine drawing a line between your hip bone and your belly button.
I can stand and try to demonstrate.
Oh, so, bless you, thank you. So McBurney's point, please, Indy. So the point, a third of the way between your belly button and your exactly, and a third away from the hip. Okay. Perfect. That's where your cecum, that's where the right colon is. And then with 2 or 3 fingers, you just make circular motions there, deep enough as though you're trying to squish an avocado in a shop to see how firm it is. So that kind of pressure. But keep like that, and then do that in a circular motion for about 10 seconds, and then travel up towards your liver, up towards your right rib cage. In a sort of straight line, swing as a sort of a loop across to your left rib cage, then just across your transverse. Keep making that motion just all the time, that circular motion with 2 or 3 fingers, squeezing firmly, that's it, along the way, and then vertically down towards the same point where you started off on your right. And that's more or less the journey that a colonoscopist makes in reverse, but that your stools are making. And again, there's some really nice data suggesting that actually helps increase transit rate.
Okay, wow.
The whole process in our patients who get good at it, they can do it, or their partner can do it from top to bottom in about 4 minutes.
Do that lying down?
It doesn't matter, whatever works for you, but because you're stimulating peristalsis, it's not gravity, you're just stimulating peristalsis rather than anything else.
Well, I'm just going to give you 1 minute, Anton, to give some hope. I think you've really given a lot of great information here. A lot of patients have been so excited about you just actually putting out in the universe the fact that fecal incontinence is very common, and probably most people have been not telling anybody about it because they think they're alone. So I think this has been very helpful to people just to know about that. But I'll give you a minute just to close, and I want to thank you so much for joining us in your evening over there in the UK and taking the time and then sharing some resources to follow up and just being inspirational in such an important field. I really appreciate it.
Kind of you, thank you. I'll definitely do that. I'll definitely share. And I like being available. So if I can help with anything, please feel free to either come directly or via the group. I mean, if there's anything I would say is don't be archetypally British and talk about your bowels. Be comfortable mentioning them. We all have them. We all use them every day, or try to. They are a cause of distress for us, whether we make noises. Often the continence issues are often to do with wind, and one of the things we haven't talked about is farting. Sorry to finish up a talk about that, but and how and control of wind is a real issue. And there are again some simple things. And if ever you get me back, I can spend an hour talking to you about wind. No, but there's other things we could do just to follow up. And there's bits about this which are really, most of what I do is dead simple. All the research stuff I mentioned is esoteric, and that's, who knows where that'll go. Most of the stuff that's fun in this for me as a clinician is the stuff that we can do, the simple stuff. So ask, there's increasingly stuff published, and yeah, it's important. In a year's time, most of our patients who've come to us say, look, I've forgotten how miserable it was. That's not because we're brilliant, because the team is great, but it's mostly because the things we do are simple and achievable.
Okay, well, I really appreciate it. And we'll definitely have you back on, because this has just been such a wealth, and there's like millions and millions of people wanting an hour on wind, saying that would be awesome. So, and they've been so appreciative. I wish we'll try to share the comments with you after, because there's millions of them coming through, and this will be available to patients to rewatch, because I think there was so much information. And then we'll link your website, and then maybe we could have you and possibly your group facilitator back on, and love to continue the dialogue, because I've learned a ton just in the last hour. So thanks again, Anton, for sharing.
Thanks for the invitation.
Yes, absolutely. Back to you, Andrea.
Yes, thank you. I will be rewatching this. I took a ton of notes, and I think as a great send-off, let's talk about it, talk to your doctor, let's keep learning more. So thank you so much for starting the dialogue, teaching us so much, and we always give our gratitude with a wave. So if you put it on gallery view, you can scroll through and see all the smiling faces. Just thank you so much, everyone, for joining us. And thank you, Dr. Emmanuel and Dr. Subramanian. Have a great day, everyone.